Bismillah ar-Rahman ar-Rahim. Welcome again to Edu-PIC if you have been following us, and welcome to the channel if this is your first time. This is Ahmed Gamal Sharif. We're going to be talking about acute kidney injury and renal replacement therapy in PICU, and we're going to be shifting ideas as we're shifting fluids as well. Our objectives of this talk, and hopefully the talks coming afterwards, is going to be understanding AKI, indications and aims of RRT, which is renal replacement therapy, types of RRT, and understand the mechanisms and principles. So, Chapter 1, Acute Kidney Injury. So, acute kidney injury is a common critical illness complication and is associated with significant morbidity and mortality. Its incidence has been rising primarily because of the increased access of intensive care and the advancement in cardiac surgeries, bone marrow transplantation, and care for premature infants. The incidence in critical care specifically has been significantly higher. So as you can see, it goes anywhere between 10% to 46%. And this is about critical illness, not about PICU admission, as there are studies that prove that about 50% of patients going to PICU will be admitted with an AKI at the beginning of their admission. You can see that the percentage is really high in patients who are coming as trauma patients and those who are requiring mechanical ventilation with respiratory failure. 64% of the patients who get on ECMO will have AKI. 45% of burn patients, anywhere between 30 to 56% of patients who have received a congenital heart disease surgery, 70% to 45% of hematopoietic stem cell transplant patients. It's quite a decent complication. So, what causes acute kidney injury and why is it so common in critically ill children? Well, as you must know from any textbook from before, you can divide the reasons into pre-renal, renal, and post-renal. Pre-renal is mainly related to the supply getting to the kidneys. So if your patient has had any kind of hemorrhage that has been significant enough to affect the blood supply going forward, or if it's a patient who's been severely dehydrated, or a patient with low cardiac output, a patient who's coming as a burn victim, losing a lot of insensible water loss, any reason that would affect the blood supply going forward, including possibly obstructions like renal artery stenosis, that would be a pre-renal cause. While the renal causes are related to the kidney themselves. So diseases where kidneys can get direct hit, as in vasculitis, HUS, as an example, would cause renal injury. Also, nephrotoxic drugs, toxins in general that would hit the kidneys, infection like in pyelonephritis, all of these reasons are going to hit the kidneys. Post-renal is more about obstructing the way where the kidneys usually would drain their output. So any reason that would affect the ureteric pathway all the way down to the urethral pathway, where you can get obstruction, have that obstruction been coming from the outside, like in possible increased abdominal compartment syndrome, where the intra-abdominal pressure is high, affecting the ureteric pathway? Has it been from the inside, like in stones, like in stenosis, congenital stenosis, or a blocked catheter, which is one of the simplest problems? These are all post-renal causes. Then you also need to remember that there are more complex causes which would enwrap lots of those, like sepsis. Sepsis would affect the pre-renal pathway and the renal pathway altogether. So you need to remember that as well. Well, how can we identify acute kidney injury? There are different classification systems over the years. There has been the rifle, which was modified from the adult world to the pediatric world via the P rifle, and then the AKIN, and then the KDIGO, and they're all acronyms to longer names. What you need to know is the KDIGO is the most recent, and it's been updated lately in 2015 as the latest. And so, following the most up-to-date guidance, which is again the KDIGO, Kidney Disease Improvement Global Outcome Guideline, how to identify AKI has been stated through three different pathways. So either you've got an increase in the serum creatinine of more than 0.3 milligram per deciliters, or you've got increase in the serum creatinine of about 1.5 times the baseline or more within prior 7 days, which states what is the baseline. So that's why you need serum creatinine on admission for any patient. Or the other way is to get urine volume being decreased down to below 0.5 ml per kilogram per hour for 6 hours or more. The problem is serum creatinine is a poor marker of AKI. And that's because by the time it's accumulating in your blood due to lack of creatinine clearance, then the AKI has already happened, possibly days before. And because of that, they are trying to come up with novel biomarkers that can pick up AKI a bit earlier. As an example, neutrophil gelatinase associated lipocalin can pick up AKI 2 days earlier than when your serum creatinine would rise and become an indicator. And that's just one of the examples listed there. Well, KDIGO also identifies 3 stages of AKI. They get identified as follows. AKI stage 1 is identified by having a rise in serum creatinine baseline by 1.5 to 1.9, or by having your patient's urine output being below 0.5 ml per kilogram per hour for about 6 to 12 hours. If the rise in the serum creatinine baseline goes anywhere between 2 to 2.9, then you're at stage 2. Or if the urine output keeps being below 0.5 ml per kilogram per hour for more than 12 hours. AKI stage 3 is identified by having 3 times or more the baseline of the serum creatinine, or if the urine output remains below 0.3 ml per kilogram per hour for more than 24 hours, or if the patient has got anuria for more than 12 hours. But does any of that really matter in managing AKI? Like, you've identified the stage. Why does it matter? Well, you need just to know how we manage AKI to realize that actually it might be a bit trivial from that point of view. So how you treat AKI mainly is by identifying and treating the cause. You're not treating the stage. You're not changing your maneuver because of the stage of the AKI. You need to know why it's happening. So go for a bladder and renal ultrasound scan, get your blood sent, send a urine sample. If all of that can't help you to identify the cause, you might need more imaging and you might end up needing biopsy. You also need to be careful and treat life-threatening consequences of AKI, like hyperkalemia and profound acidosis, while you're still identifying the cause. And otherwise, you need to remember, because if you're in a PICU, if the patient is oliguric, then catheterize the patient so that you can really pick up what's happening with the urine output specifically and calculate the balance. And that would also help you to support the kidneys. Supporting the kidneys can go in different steps. So you need to adjust the drug doses and intervals according to your GFR. And you also need to improve the cardiac output because that's going to improve the pre-renal element. You need to correct the dehydration if that's part of the problem, or if you're even suspecting it. Again, because pre-renal AKI is easily correctable. Insensible losses would be your go with just calculating the urine output and replacing it if the patient, from your point of view, looks euvolemic or possibly overloaded. Please flush the catheter if appropriate, because that's if it's post-renal, then it's quite quickly correctable, and if it's caused by the catheter being blocked, then that's iatrogenic. You don't want that. At the end of the line, you've got renal replacement therapy, which we're going to discuss in a couple of minutes. So one of your aims in managing AKI is to know where is the AKI coming from. As we said, identify the cause. Is it pre-renal? Is it renal? Or is it post-renal? As you can see here, there are some ways to try to identify that, like knowing the BUN creatinine ratio, because if it's above 20, that's pre-renal, but if it's less than 10, it goes with any of the other causes. Urine sodium in children, if it's less than 10, then it's pre-renal. If it's above 20, then it's any of the other causes. As you can see, neonates have got different numbers, and then this is the fraction excretion of sodium. If it's less than 1%, and if then it's pre-renal. If it's more than 2, then any of the other causes in children. The urine osmolarity, again. So what's the main theme here? The main theme here is any of these ways will tell you if it's pre-renal or not, but it's not really going to tell you anything else afterwards. All right. One great tool also that would help you to manage the AKI and know where it's coming from is the ultrasound. And this is something that people sometimes miss that is really important. When you're ultrasounding kidneys, you can identify a lot of problems right away. First, if you look at the renal echogenicity, then you can possibly know if there's any renal cause of the AKI, because if the renal echogenicity is high or low, then there is something wrong with the kidney itself. Hydronephrosis also can tell you if there's an obstruction afterwards, which will quickly identify post-renal problems. If you look at the IVC, the inferior vena cava, with the ultrasound as part of your scan, then that would possibly help you know if the patient is overloaded or dehydrated. It's not really that specific, but with clinical details and your assessment, that would be really helpful. Always remember to scan the bladder, and actually scanning the bladder can be really useful to learn even if you don't have other expertise with scanning the abdomen or scanning the kidneys, because it can tell you if the kidneys are producing urine and you can quantify sometimes that urine roughly, which would help you to know if just putting a catheter in that patient or flushing the catheter would help. And then don't forget that renal Doppler would tell you a lot about the renal artery and the renal vein elements that would be affecting the kidney from a pre-renal or renal point of view. Then we did mention something about the GFR, or the glomerular filtration rate. We usually calculate that using the Schwartz equation, which has got new modifications as well. But rather than going through the details, I just want to say that we really don't change the management according to the GFR, except for our drugs and medication alteration and intervals. So you can always visit that when you establish the definition of AKI and adjust your drugs accordingly. Okay, Chapter 2, Principles of Renal Replacement Therapy. So because everyone loves the definition, here's the definition for renal replacement therapy. It's not going to change what you learned today, but basically you just need to remember that it's a life-supporting therapy rather than a treatment. So what I want you to really focus on is what are the indications and aims of renal replacement therapy. You need to know when to go for it. So one of the main themes is removal of solute and water in cases of fluid overload. So fluid overload is our first indication, and that needs to be an overload that you can't manage medically. So a patient that is not really getting a lot of urine output, or not easily diuresed, or there's no more capacity for you to use diuretics. Electrolyte abnormalities, like as we said, as hyperkalemia or severe hypernatremia, that they need to be resistant to medical management. So in case of hyperkalemia, as an example, you should have exhausted the trials of using bicarb and insulin dextrose, salbutamol, and calcium. And if you use all of that and you can't do anything further, if you don't have any more facilities, then you need to think about renal replacement therapy or dialysis. Our third indication on the list is severe persistent metabolic acidosis that is again unresponsive to therapy. So if you found yourself in an element with a patient who's got metabolic acidosis that comes possibly from an AKI or an inborn error of metabolism, and you can't fix it without giving it lots of bicarb, then possibly this is the moment where you should think about dialysis. Uremia that has got complications like encephalopathy as an example. Inborn errors of metabolism, not all of them, possibly mostly the urea cycle defects or cases with very high ammonia levels, toxins and drugs, all of these can be indications. And at the end, not 100% indications, but just controversial indications. So there are theories about using dialysis for sepsis to remove cytokines. To be honest, the evidence is quite weak for that, but there are some people that still believe in it. Rhabdomyolysis. Well, we do use renal replacement therapy for rhabdomyolysis, but the question is, do you use it just because there's rhabdomyolysis, or do you use it when you've got, again, profound AKI as a consequence of rhabdomyolysis? We've got either metabolic acidosis or electrolyte abnormality or fluid overload. So that is the question. Do you just use it because you know there's rhabdomyolysis, or you wait until you get one of those? And the last one is liver dialysis, which some centers would advocate for liver failure with, again, high numbers of ammonia. Just to say that we know the indications, but the timing to initiate renal replacement therapy is quite controversial. Most of the studies come from the adult world, and there is no good evidence to prove if early renal replacement therapy is better than late renal replacement therapy. So should you really rush for it, or should you wait until you've got established indication, is still a major question. Then the types that are used usually for renal replacement therapy are in pediatrics, mostly peritoneal dialysis, and emerging is continuous renal replacement therapy, or CRRT, or CVVH, and CVVH-DF, and we're going to talk about what these letters mean in one of the next talks. Slow, low efficiency daily dialysis is mostly not an ICU setting, and intermittent hemodialysis is the one that is usually conducted in renal units on wards rather than in an ICU setting. So what are the principles and mechanisms of renal replacement therapy that you need to know of before we kick forward with the next talks in next sessions? So diffusion. What is diffusion? Diffusion is the mechanism that gets solutes transported across a semi-impermeable membrane just by concentration gradient. So if you've got low solutes or low concentration on the dialysate here, then you're expecting the higher concentrate of these solutes here to just diffuse to where there is less concentrations. And the other way around, if you want to give something into the bloodstream, you can use diffusion as a mechanism. But in dialysis, we use it to get particles out of the bloodstream. So the bloodstream gets less of the toxins, and the dialysate can carry that outwards. So the composition of the dialysate, as you can figure out, determines the concentration gradient. So basically, if you've got highly concentrated dialysate, then basically you're going to get less solutes out. If you get less concentrated dialysate, then you're going to get higher amount of solutes out. Is that the only thing that affects what you get out? Well, actually not just the concentration, it's also the flow rate. So how long do you keep the fluid in or in front of the bloodstream would affect the amount that you diffuse out, basically. All right, so this is diffusion, and it happens passively. Convection is a bit different. So convection basically gets solutes across a semi-permeable membrane along with some fluid as a result of solute drag. And that drag happens due to a transmembrane pressure. So the pressure needs to be higher on the blood side to get the solute and the fluid out to the dialysate, and that would get more fluid out as well, and that is basically under pressure, so it's a bit active. While ultrafiltration is just basically the shifting of fluids through a semi-permeable membrane. Basically, if a type of fluid finds holes in front of it, it's just going to pour out, and that happens just according to a pressure gradient, but it doesn't have to be active force. The last definition that you need to know of is adsorption. Adsorption is basically where some molecules just get adhering to the surface of the semi-permeable membrane, but don't really pass through it, but they still get left behind from the bloodstream. So the bloodstream actually goes forward, being cleared of these molecules. And that's it, basically. These are the principles that we wanted to lay down as foundation to our next talks about peritoneal dialysis and CVVH, and hopefully it's going to be a useful run. Thank you so much for following, and these are some references that we've used for this talk. Thank you.